So for those of you who've been attending our session over the years, Chip has been here before. People really like the extraordinary data and benchmarking he gets from the work that he does working with practices around the country. And it helps us sort of level set and understand where we are relative to all that and how to get better.
All right, thank you.
Dr. Hart.
Oh, yeah, I wish. All right. All right, I did Wordle in 2 today, so that's going to be my good luck charm. How is everyone? You're tired? Can you imagine going to these things before Wi-Fi? All right, and so you had to actually pretend to pay attention to me. Now you're all typing. Whoops, I get it. I would be doing the same thing, especially when we're going to open with a potentially incredibly dry and boring topic, benchmarks. But I will do my best to make it somewhat interesting. Before I begin, however, I would like to really express my appreciation for being invited back here. It is really weird to present to actual people. As some of you know, I've been doing a lot of speaking the last 3 years, but it's mostly to a screen and a microphone. And when I can actually get feedback from people, it's a little overwhelming. I don't say this to pander to you at all, but this particular event, I've spoken all over the country, and this particular event has the most fascinatingly diverse audience in the country. You're also some of the nicest people, and you actually engage with the speakers in a way that a lot of other places don't. So I always enjoy coming here. I learn a lot from being here myself, which is helpful because everything I learn, I try to share then with the people who don't get to come here. So I'm going to talk about a subject that's near and dear to my heart. And for most of you, you just hope you know someone who this topic is near and dear to, so you don't have to worry about it. And I'm going to do something. I'm going to open a slide deck with the thing I hate the most in a presentation. Well, there are 2 things I hate. When a presenter opens a presentation with a cartoon, and oh my God, I just realized I say that. I hope none of the presenters following me do that today. Or you should never make me first. Or if you open up with the dictionary definition, but I do this one on purpose because I do need to level set and get everyone's focus on what I'm talking about today. And the word is benchmarks. Now, in theory, everyone in here who went to med school is at least a little bit of a scientist. And boy, your science credentials have come roaring back when COVID hit because you've had to brush off some of the ideas relating to, one of the most amazing human, I don't want to call it discoveries, but understandings of all time, the scientific method. We have a hypothesis, we test it, and then we see what happens. And you cannot do the work that is so important in your lives if you're not measuring. I mean, I'm going to be talking largely about some clinical and financial benchmarks. And, you'll glaze over a little bit, but can you imagine being a pediatrician without any vital signs? From here, you look like you're feverish. All right. You look like your blood pressure is a little high or a little low. You can't operate as a pediatrician without data. And I'm not going to suggest, I'm going to straight up tell you, and I know you know this intuitively, I'm just trying to get you to stop avoiding it. You can't run your business without taking vital signs, and you can't actually look across your patient systemically or holistically without taking vital signs. So I'm going to talk about them, but before I begin, so a benchmark is a standard or a point of reference. I'm reading. Against which things may be compared or assessed. All right, so why are we using them? We are using them because you all operate in silos. And yes, we all know that 98.6 degrees is a standard reference. It's a benchmark, and that tells us whether or not a kid is running hot, running cold. I was actually hoping that list of descriptions of the room some people will use in their comments about my talk. I thought pleasantly cool was a good way to describe my talk later, or whatever it was. But you need to use them because the only way to gauge your own performance, your own growth, the quality of your work, the impact you're having on your patients, the potential success or demise of your practice and what you do is to measure yourself. You need the equivalent of the door frame that says October 1st, 2021. I was, 5'1", and then I grew an inch. You need that for your practice. You also need it because you're being measured right now by a lot of people. You're being measured by the payers. You're being measured by the government. The presentation after me is about value-based payments. All right. And that's all about benchmarking. You're being measured now, not by the number of CPTs and RVUs you do, but by a series of fractions, this number over this number. And if you don't get your head around ahead of the people who come in and say, oh, by the way, this is how you're going to be measured, if you're just going to let it happen to you, I guarantee you, you will be unhappy. I also will guarantee you that if you are not paying attention to some of your measures, you are not taking care of your kids properly. Ignore the money part. There's no way that you can actually manage 1,500 children without benchmarking your performance. You can't do it properly. No one in here is actually mentally, well, maybe Sandy Chung, but no one else in here, all right, is capable of knowing the status of all 1,500 kids or whatever your number is. And who's up to date, who's had their vaccines, who's had their developmental screening, who needs. We're going to go through these. I'm going to show you some of these measures. Now, where do you get them? Where do you get these benchmarks? You get these benchmarks in a couple places. First of all, they are handed to you or thrust upon you by your value-based care overlords or the payers or the MGMA or the AAP or various formal places. I'm about to give you a few dozen benchmarks. In fact, I am not going to have enough time today to go through all of the benchmarks I've prepared for you. I deliberately dumped as many of them into this file as I could, regardless of the amount of time I had to present, because you will get this PDF from our friends at Children's National. You can reference it later. I publish all of these numbers on my blog. I do this constantly throughout the year. I've been doing this for how many years? I probably have 700 blog entries, and I talk about benchmarks all the time. We try to give them away for this purpose. I want to make you better pediatricians because the work you do taking care of children is so important. So there are sources of these out in the world. However, the single most important source for benchmarks for your practice is your practice. The most important person to compare your performance to is you yesterday. Right now, if I say 185 pounds, that's how much I weigh. I kind of wish, but let's say I weighed 185 pounds. I have weighed 185 pounds a couple times. 185 pounds, is that good or bad? Kind of depends on how old I am, how tall I am, what kind of shape I'm in. How can you have your benchmarks need context, and the most important context for you is what you did before. So I mentioned scientific method, and the whole concept of scientific method is that you have a thesis or you have a starting point and you perform a test and then you remeasure to see what happened. And so when we talk about, I'm going to be talking about it this afternoon, actually, because we're going to get to this, your well visit coverage rate for adolescents is 73%. I want to run a patient recall program. You run it, and then your adolescent well visit coverage goes from 73%, we hope, to some number like 80%. That's why your benchmark is important. It doesn't matter if the people around you are at 85% or at 60%, as much as it matters that your work changed your practice. There are so many variables that affect your performance, many of which are outside your control, that comparing yourselves to everyone else is not as important as comparing yourself to you. So I'm going to show you a bunch of benchmarks in a little bit, and I'm going to show you what the distribution of these benchmarks look like for independent pediatricians. I'll describe all this. If you see a number up here that freaks you out, I'm sitting at my at my little booth out there for the next 4 or 5, 6 hours. You can swing by and I will explain it to you, but I can also probably talk you through how to make sure your number or what you feel is okay or not okay. I mean, I guarantee you there are people in here with some really bad and scary benchmarks. But let's talk about them now, because I want to get to the good part. Now, what makes a good benchmark? I could share all kinds of very complex data points all day long. I'm a nerd. I like to do it. However, a good benchmark to me is a very simple number, and it's a starting point. So what I've tried to do in as many cases as possible is reduce a measure to a single number. That single number, by reducing what we're looking at to a single number, that means we're often oversimplifying what we're measuring. And there's more to the story, but it's a starting point. A classic example is going to be the first example I give you. It's the first example because it's the least important example for the rest of my talk. That's the concept of AR and AR days. Okay, AR days is just a simple measure that allows every organization in here to compare their level of accounts receivable. How quickly do you and how well, in theory, do you collect your money? But how do you compare a 1 doctor practice to a $20 doctor practice? Pardon me. How do you compare those two? They're such different sizes. AR days is the method you use to do that. I've simplified everything to one number. It doesn't tell you the whole story. It only tells you one little part. But a good benchmark is simple and easy to understand. I've done my best, and I've even given you the calculations for this. And everyone in here has a system that can run these numbers. If your results differ from what I show you, and in many examples, I'm actually going to share with you a distribution graph so you can see where you appear relative to your peers. And what's interesting in pediatrics is that many of the distributions are not normal distributions. They're very skewed. And so you may see that you're on one end of the skew or the other end of the skew. And what do you do about it? Well, what you do about it's going to depend on the benchmark and where you are on that skew. You might get to pat yourself on the back. You might need to start a new project tomorrow at work. All right. I'm glad to give anyone advice about anything they see on here. All right. And where can I ask questions? Look around, look to the person on your left, look to the person on your right, the people who might have a benchmark that's different from yours. You can ask them about it. You can also go to SOAPM. You can also, all of the academy is a great source for how to address the things I'm about to show you. And last but not least, I need to give you a big warning about the data I'm going to show you. And the reason is because the sample source comes from the customers of the company I work for. Okay, we're a pediatric EHR, and that's where I get my data. So it's a skewed sample set. These are all independent pediatric practices around the country, which suddenly you're like, well, that doesn't sound very skewed. Well, they all happen to choose this one vendor. So if there's a common thread, like maybe they're just the coolest people, their behavior is going to be different. And I will tell you, their behavior is different because they pay me to yell at them to change their behavior. All right. So there is a distinct bias to this data. And in fact, I have seen data from other vendors and it does differ. Well, I don't even have to pass a judgment on it. Like our clients are better. No, I can't even make that judgment. It's just that the way that I've measured things and the way that I analyze things is enough to be that possibly that when you look at your data, there's a difference and your practices aren't even different. It just has to deal with issues of measurement or style. Okay. Here's one big thing. COVID has screwed up all the benchmarks. All right. We had a 30-year run where everything was a smooth, straight line. We had a couple hiccups, like when H1N1 hit and there's some big RVU changes. You can see these blips or these jumps and they're kind of fun, but COVID wiped it all out. However, it's been really interesting how quickly things have returned to the norm. I know that things don't feel like they've returned to the norm, but your performance has gone back to normal. I'll give you a really fast executive summary because I'm not going to talk about this much. And I think I actually presented about this here remotely, but when COVID hit, we all freaked out. All the sick visits went away. Everyone panicked. However, pediatricians found themselves with a lot of open slots, and they had a lot of kids who needed well visits. So I will tell you, at the end of 2020, at least among our clients, but I believe this to be true nationally, in independent pediatric practices, more kids had well visits at the end of 2020 than any point in American history. In fact, every single preventive care measure that we track was higher at the end of 2020 than it was at the end of 2019. However, the ebb and flow of visits and people and the tridemic and everything like that, we've had 2 or 3 runs. I mean, you know this. If you remember, you were really busy through 2020. The beginning of 2021 was really bad. And then the fall of 2021 was gross again. And then spring of 2022 slowed down a little bit and people started to breathe. And then everyone went back to school. Everyone south of the Mason-Dixon line, or like, let's say from here down, starting in August, everyone got sick again. And it's been the busiest. I mean, correct me right now, but most of you are looking pretty good in the bank because you're seeing 30 kids, right? And your well visit numbers went down. So your numbers are back to normal. All right, which is kind of sad. I was hoping you maintained. But let's talk about the numbers. This is like I'm for the number of people among you, and you know, many of you did go to med school here, so this should be most of you. This is where we get to have some fun. I'm going to start off with the boring money stuff, and then we'll get into some of the clinical stuff. And they're going to cut me off. I'm not going to get to the end. A couple of these slides I'm going to skip because I can just go on to a more interesting one, and you can come back and look at the PDF. All right, no one's nodded off yet. This is a good start. Let me show you. What you're looking at here is the general format of the data I'm going to share with you. I have a title at the top. I have an explanation, AR days, what it measures, and then I tell you how to calculate it. And right now, I don't, if you don't care about this, you're an employed doctor, give me 10 minutes, 5 minutes. We'll get to I'm starting with the measure that so many practice management consultants use as a way to tell you why you need to pay them money. This is like it's a classic old consultant trick. I can tell you this because I'm a consultant. You go in, you measure their AR days, you do some work, and then you measure their AR days again using some slight math tricks, and you're like, look, I lowered your AR by 30%, and whether you did or not, who knows? But what you do is you just take your accounts receivable. How much money do I have outstanding right now? Everyone's billing system can tell them that. And then you divide it by the average amount of the average charge volume that you have over a time frame, and it gives you a number. And this is what that looks like. Now, most of my slides then look like this. I'm going to show you the real values, and then I'm going to show you a distribution of AR, or in this case, and I'll show you what this means in a second, and or I might show you the value over time. Because it's January 2023, I don't have many 2022 values yet. We need to, you guys know how it works. Some of you in here haven't even entered your charges for December yet. All right. So we need to wait like a month or two to get all that data in, and then I can get you 2022 numbers. But I have this running scale going along. You'll see some stuff. But this is what AR looks like. And you'll notice, take a look at the blue line, or we'll look at the mean. In 2019, the average AR was 27 days. All right. Now, people like to say that means on average, your practice takes 27 days to collect the money. That's not actually what it measures, but it's close enough. And that's what we talk about. In 2021, fascinatingly, that number had dropped. Now, that's because you were on top of your billing during COVID, because you had to be. All right. What's interesting is that in 2022, that number has grown. Now, the median hasn't adjusted as much. All right. The mean has adjusted. And what that means is, I'm sure some of you remember your statistics class. Some people have shifted out to the right. But take a look at that blue line. That blue line represents 2019. More people were skewed to the left. We had a bigger chunk of people who had very low AR. And then it slid out. But like I said, this is boring. This is boring. I'm bored by it. So the one number that I will tell you as a consultant, for those of you who are in private practice, for those of you who actually own your practices in here, use this number instead. I want you to track the percentage of your accounts receivable that is more than 60 days old. Alternatively, because I didn't show this slide, I want you to track your accounts receivable that's between 60 and 90 days old. It's a very specific segment. Okay. And the reason is this will show you if something is happening in your billing department. Because what happens at 90 days? You can't submit that claim. So all of a sudden, well, you can, they can just refuse it now. And if all of a sudden you see that your AR is growing at that space out there, now you have to set off the red alerts. And so what you do is you just take all of your AR that's over 60 days and you divide it by your total AR and you take a look. And this is what that distribution looks like. Okay. We'll just say on average, because we're going to use the mean for that. Right now, 30% of the accounts receivable, 31.9% of the accounts receivable in 2022 for pediatric practices nationally is more than 30 days or 60 days old. And here's the thing, your practice, you might be at 10% right now. Your practice might be at 40% right now. We can't tell. I will tell you that if your practice is at a 5 or 10% AR over 60 days, you may not actually, in fact, be a better collecting practice. You might have staff who are writing things off really aggressively. I don't know. But what I do know is you should be measuring it, because if it goes from 5 to 10% and you don't know why, that's a red flag. If it goes from 20% to 5% and you don't know why, that's a red flag. You need to know your number. And this is an incredibly easy number to measure. I'm going to start getting more interesting. Well, let me say this. These numbers are more interesting to me, and I do a lot of pediatric practice management consulting. So if they're interesting to me and they're not interesting to you, something is wrong. Not so much with me, all right? So if I'm not hitting the mark, I want you to think about it and maybe tell me, like, this isn't important to me and here's why. But this is a key one. This is one of my top 5 magic measures. It's revenue per visit. This number tells you so much. I can tell you, I can play parlor games with a pediatric practice with 2 or 3 benchmarks. I can tell you how much money you make as a pediatrician. I've done this hundreds of times. I can usually guess how much someone makes within $5,000 or $10,000. And this is at the top of the list. And the revenue per visit is very simple. Add up all your revenue, count all your visits, divide one by the other. And you will notice, all right, let me take a look at this. I've broken it down. The revenue per visit has changed over time. I am blowing through some of these numbers because you can go back and dig into them in a little bit, because I want to show you. Wait, let me see. I want to show you this number here. I'll back up one in a second. But I want you to look at the average revenue per visit over time for pediatricians. We've been measuring this for, well, we predate 2003, but here it is for 20 years. And you'll notice it climbs, and then it drops in 2009. Does everyone remember what happened in 2009? H1N1, right? That was that year. And so that revenue per visit, all right, the revenue per visit dropped, but that didn't mean your revenue dropped. It's just that you had a zillion extra visits that year that were low revenue. Look what happened when COVID hit. So 2020 had the biggest leap up from 151 to 159, and that's because your ratio of well visits to sick visits increased massively in 2020. And then it dropped right back down. And we're going to talk about the sick to well visit ratio in a bit. But over time, 20 years ago, the average revenue per visit for pediatricians nationally was half what it is today. And people are here like, no, it wasn't. Go measure your own. If you're on a computer system, you've been on the same computer system for 20 years, you can go run your own report. This is actually a very simple report for you to run for yourself over time. This is what the distribution looks like, just so you know. Visually, ignore the dotted lines for a minute, okay? Just look at the solid lines. And what you'll see is that there's a pretty big collection. If we look at the blue line, 2019, pre-COVID, there's a pretty big collection. Most practices are between $140 and $170. And then there's a pretty long tail in both directions. When we remove immunizations from the equation, which we really need to do to normalize things, because there are plenty of people who are in states where everything's universal, or we have practices in here who have a ton of VFC, and we have practices in here who have no VFC. If you remove the immunizations, that's where the dotted lines are, you'll see that the numbers start to collect. They get tighter. And what we see, if we look at the green dotted line, okay, that's my 2022 numbers. We are in, without immunizations, most of you are getting between $120, $110, and $130 per visit. And that's the very easy number to add up. Add up all of your revenue, subtract your revenue for the immunizations, not the admins, but the product itself, and then divide by the number of visits you did. And any change we make for any of the benchmarks that I'm about to describe next, you want to come racing back here and say, what did that do to my revenue per visit? Did it make it go up? Did it make it go down? All right, I'm going to change gears and talk about coding, everyone's favorite subject. So how do you use after hours codes? Everyone familiar with these? The 905, 99050, 99051, 99058. All right. Some of you use them all the time. I mean, you are aware, I hope, that if you see a child after hours, which let's not debate it at the moment, but let's say it's every kid after 6 p.m. Personally, I'd say like 4:30, but let's say 6 p.m. Every weekend, every holiday, automatic is a 99051. Some of you do that all the time. Some of you in here don't even know what I'm talking about. Some of you put a 99050 on that, and that will get you audited and lose. All right. And some of you randomly put 99058s on things for reasons I don't understand. But this is what that distribution looks like. In 2021, I haven't assembled all of my 2022 data yet. And I couldn't just cut it off because, boy, the last 2 or 3 months have been crazy, and I don't want to give you a bad number. But in 2021, 3.1% of your visits were marked with after-hour codes on average. But you'll notice that is a long tail. What I mean by that is take the 2019 line, which is the blue line. In 2019, okay, almost 25% of you never billed an after-hours code. That's that 0% on the x-axis, 25%. It's just under that 25% line. Everyone, there's my mouse. You can see that right there. 25% of you never billed this code. How are you possibly going to explain to Blue Cross Blue Shield why you should be paid for this if you do not bill it? If you haven't counted it, it didn't happen. Okay. 20% of you only billed it 1.5% of the time. And maybe that's legit. Maybe that's the right number. But then you'll see there's this long tail, and there's this really funny thing out here where some batch of people billed it 10% of the time almost. At 9% of the time. What's right or what's wrong is academic. Okay. It's this, I can't tell you, you should be billing this 8% of the time, 10% of the time. If you're not open after hours, I can't tell you to bill this. But if you are open after hours, if you are open on weekends, if you are seeing people on national holidays, then you should be using these codes. And this should give you a sense of what your peers are doing. There are people, just so you know, there are people billing this code. So for the 1 in 4 of you in this room who are not, and for the 2 in 4 of you who are almost never, you have a lot of friends around you who are using this with some consistency. Honestly, if the entire result of this entire conference is that a half dozen of you start using that one simple $5 code, it's actually a victory. We're going to take it to the man. Anyway, so pricing. This is a fun one. Right now, most of you get a voodoo doll out to choose your prices. All right. Some of you know that there's a free RVU pricing calculator out on the market. And some of you even know that I'm the guy who does it. All right. And I just did 2023. It's free. I do it because the AMA wants to charge you to do it. And that offends me. So it's free. I want everyone to use it. There's no sales pitch in it. You just download a Google sheet. Okay. But understanding your pricing is really important. I give a whole 45-minute lecture on this topic. I am not exaggerating at all when I can tell you I have helped practices earn hundreds of thousands of dollars, individual practices, not collectively, hundreds of thousands of dollars more than they were the year before because their pricing was wrong. Now that is like a Weight Watchers ad. Your results may vary. You might already be doing well, but I've seen some practices who are priced so poorly and they don't know it, that they were losing hundreds of thousands of dollars a year. So let me tell you how this works. Actually, if you go use the RVU calculator, it does all the work for you. But let me show you something. This is what pricing looks like nationally. And you notice they all sort of center right here. Right now, at least certainly among our clients, the average PCC client charges about 190% of Medicare. Now, before anyone here gets offended, realize that your other specialty friends charge 300 to 400 to 500%, and the hospitals charge somewhere between 500 and 2,000%. They have to publish their prices now. What do you think I did the day that was a mandatory requirement? I went out and downloaded a bunch of fee schedules, and I was like, holy cow. So this is what pricing looks like over the last 20 years. 20 years ago in 2003, on average, pediatricians charged 134% of Medicare. You were also collecting $79 a visit. Today, at least among our clients, you're about 185, 190%. And I'm going to explain some of the dips here in a second. And you're collecting, $150 a visit, $160 a visit. The correlation should not be ignored, but there are a couple big dips. Now take a look. In 2020, our clients were at an all-time high, 193% of Medicare. And just by the way, of all the things that we yell at our clients about, this might be the biggest one. And so I assure you that the average pricing in this room is probably below that number. This is one where there's some significant bias. So, but let's say you're all at 193. Well, on 2021, everyone dropped to 180%. Did anyone lower their prices in 2021? Don't raise your hand if you did. That would be embarrassing. All right. You didn't lower your prices in 2021. Does anyone know what happened on January 1st, 2021? Some people knew. All right, that's good. The feds moved billions of dollars to primary care. Well, at least for Medicare. They kind of forgot about you guys. That's another story. That's why Sandy Chung is here. All right. But their intent is right, and they moved billions of dollars into the E&M codes. And what has happened is that the RVU values for the most common procedures that you do, besides the IMS admins, but the most common procedures you do, got jacked up by like 29%, 25 to 29% each. And you did not raise your prices fast enough. Remember, this is a numerator and a denominator. The denominator grew faster than the numerator did. So it looks like your prices dropped when in fact they stayed the same. And all you're doing there is letting the vice president of Optum or something like that get a bigger boat. That's all you're doing when you're not getting your prices right. So let's keep going. Your gross collection rate. This is just a fun, easy number. Remember, benchmarks are simple. I add up all the dollars. I add up what you collected. I divide, and I get a number. So I just noticed a massive typo on that slide. How many years has that been there? And no one has ever said, like, how have I never noticed? I'm like, you can't have a gross collection rate of 152%. Whose idea was that? Oh my God. So I'm going to show you something interesting. Well, I didn't put the slide in, but let me take a look at this. Your gross collection rate. How is that important? Why is that important? I mean, your net collection rate is really important. Your net collection rate tells you how much of the money I expected to collect did I collect. That number should be 98, 99%. But this is like, hey, relative to my prices, which we all know is kind of a weird game, How much did I collect? Well, this is why benchmarks are important. If your pricing today is 175% of Medicare and you use some science and an RVU calculator and you fix your pricing and you get that number to 185 just by lowering up, fixing some prices that were wrong, and you get it all set and 185%. And then you want to look at what happens to your gross collection rate. If you raise your prices, it should be no surprise that your gross collection rate goes down. But you want to see what happens. And here is a bet I'm willing to make with anyone in this room. I'll make a bet with all of you in this room. If you raise your prices by, let's say, 20%, I bet your gross collection rate does not decrease by 20%. And that's weird because it should, but it won't. All right. I guarantee you that you are pricing some things in a way that you don't realize you're leaving money on the table. The way that insurance billing works is that it's not honest and transparent. They don't show you the cards that they are holding that says, well, we'll pay you this. They will only show you, they will pay you an amount, but you don't know. It's not a fair transaction. Your insurance agreements say, we are going to pay you our fee schedule, which we won't send you, or we're going to pay you 60 or 70% of whatever you charge, whichever is lower. All right. The guys who own the casinos look at this and say, wow, we are in the wrong business. So I will guarantee you that when you raise your prices, come back and look at this number a month or 2 or 3 later, and you will be surprised by how little it has changed. All right, Medicaid coverage. What does the Medicaid distribution look like? Do people even know? Like, is my 10%? Am I magnanimous, or should I be opening my doors? All right. Or is my 70% where am I, first in line at the pearly gates? I don't know. Well, you can add up all your patients, and you can count all your Medicaid patients. You can do some math, and this is what it looks like. And I will tell you, among PCC clients, that average right now is 30%. Now you'll notice it has climbed every year since 2019. It has grown by 10%. Shocker. Right? Sadly, that's not because a number of states have decided to expand their Medicaid rolls. It has nothing to do with that. They haven't done that. And what you'll see, those lines are pretty consistent. But what you'll see is among our customer base, okay, right here, you'll see about 17%, somewhere between 15 and 17% of our clients have no Medicaid whatsoever. Sometimes by choice, sometimes by where they landed. Okay. We have about somewhere between 5 and 8 or 9% of our clients have 5% Medicaid. If you jump out here, okay, here's another, this is a very interesting little joining, or let's call it. Right here, about 9% of our clients are 25%. That's just around the average. And then look at this long tail. So most of you are somewhere between 20 and 90% Medicaid. Good for you. You're saving kids. E&M distribution. This is one that goes way back. I measure this slightly differently. Okay. I measure this slightly differently because if I show you a distribution of E&Ms, like maybe your 2s are low and your 3s are high, but your 4s are low again and your 5s are high. Like it's a complex number. So I boil it down to one thing. And here's why. First of all, most of you in this room don't do 99215s. You do them by mistake. All right. It's a typo. Yeah. Like I go and I'm like, okay, look, here's a practice. They do 14. This doctor did whatever. These doctors did 1,400 213s, 1,000 214s, and 6 99215s. I'm not here to lecture you about why that's a mistake yet. All right. But clearly it's a mistake. The E&M rules have been made generally much simpler and easier. And if you're like, well, no, you can't, it's so hard to get a 5 now, blah, blah, say they're still time-based. And if you want to tell me that only 3 or 5 times a year you spent 40 minutes on a kid, that's weird because I don't believe you. All right. And they made it easier because you get to count up all the time you spent that day. Remember, but in 2020, you had to be in the room counseling for 40, 45 minutes. And half of that time had to be spent counseling. You don't have to do that anymore. Everyone in this room who sees patients spent 45 minutes on a kid last week. Not everyone in this room billed a 215 for it. So since the 215s are kind of invisible, I just sort of squish them in with the 214s and I say, add up your 4s and 5s. What percentage of your work, as measured by E&Ms, is made up of 4 and 5s? Remember I talked about simplifying your benchmarks? Well, this is what it looks like. That number, and this is fascinating, has actually gone up with COVID. A lot of people wondered what was going to happen with the new E&M rules and everything like that. But yes, some of my practices seem to have dropped precipitously, and some of them have leapt up precipitously. But by and large, you're all doing the same thing in 2022 that you were doing in 2019. This is what the distribution looks like. On average, you're doing 40% 214s and 215s. For some of you, that 39%, I'm rounding in my head. For some of you, that's 39% 214s and 0% 215s. For some of you, that's 35% 214s and 4% 215s. For none of you, it's 10% 215s. I mean, maybe someone, but that's really uncommon. And that's what the distribution looks like. And this benchmark is crucial because the rules for charting changed revolutionarily on January 1st, 2021. And so we needed to measure it. Has anyone here actually stopped to look to see what happened with their E&Ms after the coding change? Okay, I see some yeses. Okay, good. But I did not get a resounding yes. Like, of course we did, Chip. Why are you giving this lecture today? All right. This is how I'm just going to ask you. So a bunch of you own multi-million-dollar businesses. These are the most common codes you do. They generate the preponderance of your revenue. And you just sort of are like, okay, we'll see what happens. Or what do we do? You're not paying attention to your own practice. It's right there. And this is like low-hanging fruit. Apparently, I'm using shame today, so pardon me. This number to me is really interesting, and this is the use of those codes over time. Okay, back in 2003, this is kind of embarrassing, isn't it? 12% of your visits were 214s and 215s. Of course, we didn't have the same mental health challenges, but that stuff, that stuff's really kicked off lately. But look at how quickly you have climbed the ranks with better coding education, meetings like this where you've had professional coders, all of the AAP's work. You are starting to finally, you're still not there, but you're starting to finally value your work properly and get paid properly, because I assure you, your adult friends don't have any problem billing 214s and 215s. If you don't believe me, go to the doctor. I don't know if you do what I do. Like, but when I go to the doctor, I grab that EOB or that sheet and I'm like, I remember walking out of one of my doctor's visits. I'm like, that was not a 215. Like, I know that was not a 215. All right. Yeah. My pants were on the whole time. That was not a 215. I did show for 2021 what that distribution did look like. I can't believe I just made that joke. Sorry. This is what the distribution looks like if you want to get into it. And it hasn't changed much yet for 2022. I can just tell you that. I just was not prepared with those numbers. All right. Now RVUs for visit. Now we're going to the AP class a little bit. All right. But these are also easy to calculate, especially if you have a free RVU calculator, for example. Or many of you have EMR vendors who can calculate this stuff for you. Okay. I'm just saying, if you don't have to get left behind. And RVUs per visit, something really interesting happened. This is when these numbers deviate a lot, that means something happened. In 2019, the mean was 3 RVUs per visit. You can see the mean, the median there. But in 2021 and 2022, everything shifted out a block. It shifted out a block for 2 reasons. One simple reason: you did a lot more well visits to some extent, but that right there shows you what the Fed's pricing did. The Fed's RVU shift moved your average RVUs out almost 10%. I'm sure you're like, yeah, but I didn't get 10% more money. That's because everyone forgets about the pediatricians at the federal level. It's a little painful. Not everyone, we're trying, but you didn't get the money that everyone else did. But take a look at what's happened with pediatric RVUs over time. One of the other things is, what made them go crazy starting in 2009? That is when the feds valued your IMSS admins, which was the single biggest financial boon to pediatricians in my career. As Uncle Jed shot the oil well in the backyard that day when the admins came out. They have a huge impact on the work you do. All right, here's a fun one. Here's one I made up, but I have what's the word I want? I've been able to confirm that it's got some validity, or it certainly has a really interesting correlation with the work you do. I literally now, especially when we have a new client and I'm trying to understand how they work and we're trying to introduce them to the workflows that we like to have people follow, I literally count the number of ICD-10s they record on a per visit basis. Why? Because those practices who record a single ICD-10 or as few as possible are clearly it's not a guarantee that they don't code well elsewhere, but it's a really good sign to me that they lack the discipline. Let me back up. For those of you who are PCC clients know we have a dashboard tool, and the dashboard tool has all these numbers in it. I didn't hand calculate these. I just grabbed them from our tool. And we score people, we grade people. We tell people, you got an 87 on your financial benchmarks and a 91 on your clinical ones. And people get, if you guys, for the non-doctors among you, it's so much fun to watch them get all bent out of shape about that. All right. They you want to see competitors? Give a doctor a B+. All right. They don't like it. It's great. However, and we've been measuring this forever, the correlation between strong financial benchmarks and strong clinical benchmarks is very, very strong. The discipline to run a strong clinical practice is the same as the discipline to run a good billing practices. It is very rare that those things are divergent. Very rare. So I know when I go into a practice and I see that they are not even putting diagnosis, when they are not putting any of that child's chronic issues on their well visits, that means they are not paying attention to a bunch of other things. And that is, by the way, I don't know how much time I have left, but I want you to remember this. 5 minutes, 10 minutes, perfect. When the crew who follows me talks about value-based care, this one is right there at the middle. How do you think they measure you? Right here. And this is a really simple one. And why it's simple, you add up all the ICD-10s you did last year, and then you divide them by your number of visits. And if you're really cool, you break it down by well visit and sick visit. And if you say suddenly, oh my gosh, the value-based care people just scared me, we got to buckle down and make sure we've got our ICD-10 story straight. And you do a little bit of work, you get a little bit of discipline. You measure this before and you measure this after. And if you move from 4.6 to 5.1, you have a victory. I will also tell you that the correlation between diagnoses per visit and revenue per visit is a positive one. I guarantee it. So this is a really easy number to check. All right. You'll notice over time, that number has gone through the roof. No surprise, especially, it wasn't ICD-10s way back when. ICD-9s we think of those as the good old days, right? But take a look at this number and measure your own diagnostic coding expertise. Don't squint. Don't try to take a picture of this right now, or go ahead if you want. All right, but later on, grab the PDF from our crew. just so you know, I just grabbed the top 50 CPT codes by volume used by pediatricians in 2021, because 2022 isn't done yet when I did this. And I ranked them for you. I gave you the code, the average charge. I am not afraid of getting in trouble for this because these are national numbers, not Washington, DC numbers or anything like that. What percentage of the volume, what the percentage of your volume it represented, and what percentage of your charges it represented. Why do I have this here? Because it's just a gut check. You should go down that list of CPT codes. And I assure you, if you're in the top 20 list and you see a CPT code you don't recognize, you should find out why. And if you run yours and you have some CPT codes that aren't even on this list that are in the top 20, you should either pat yourself on the back or find out why. Here they are sorted by volume. I thought I had a slide that had them sorted by dollar, but it's just the same list, different order. Again, download the PDF later or email me and I'll just email you the slide deck. I don't care. All right. New patient volume. This number is really fascinating. I'm going to speed up a little bit to get to a couple more. New patient volume, very simply, is I count up the new patient CPT codes and divide them by the total number of patient E&Ms that you've done, well and sick. It's a very easy number. New patient E&Ms by total E&Ms. Your 99381s plus your 99391s. You add them up. And this number has been fascinatingly inelastic over time. The mean right now is 4.7%. That is on average 4.7% of the patients our clients saw last year were labeled as new. Now, you have new patients that come in through the hospital who aren't marked that way. This isn't a measure of the total volume of your new patients, but this is a measure of the patients who are new for the first time in your office. And you might break this down over time by looking at it by different age cohorts. You might say, how many of our new patients were adolescents? How many of our new patients were 1 to 5? Because this tells you something about the growth of your practice. This tells you if people are moving into your practice. This tells you if people are not coming into your practice. Does everyone remember when Obamacare was being threatened and all the pediatricians, a bunch of them on up and said, oh my God, we're going to get overrun by Medicaid patients. It's going to be a flood. And it just didn't happen. Did it? Did anyone here get overwhelmed by new Medicaid patients? No. All right, not because you expanded. You overwhelmed with new Medicaid patients because people lose jobs, but not because we actually started covering kids. And so how did I know that? Because I measured it. I know that every single person on SOPM who was afraid of being overrun by Medicaid patients as a result of Obamacare, not a single one of them measured it and came back and said, oh, I was wrong. This is what you need to do to understand your own business. All right, I have a couple more that are fun. And I have to skip a bunch. I told you I was going to. It's okay. The file's in here. Same day sick and well visits. I don't know anyone who shares this data. Okay. This is, you're all familiar with the concept of a 99213 with a 25 modifier? Please nod some heads. Some of you, yes, okay, thank you. I know most of you are, but this is a hard one to figure out because the way the payers are so ridiculous, you have to throw 25 modifiers on everything half the time, even when you don't have 2 E&Ms in the same day. God forbid you give an immunization, you got to put a 25 modifier. It's a total misuse of that code. Don't get me started. But because we're nerds, we can count it up at PCC. And here's something you want to know. This is another one with a very, very long tail. Come out here. Okay. About 5% of our clients in here never use a 25 modified sick visit on the same day as a well visit. Okay. About 20 to 25% of our clients use it 1% of the time. I think I can safely say, without doing a peer-reviewed double-blind study, that more than 1% of the time, children who show up for well visits have a separate and identifiable service that they need from you. Safe to say? 1% of the time, that's 1 out of 100, so that's every 4 to 5 days. Yeah, no, it's every 4 to 5 hours. It's every 4 to 5 visits. And so you are not using this code. Now, some of you are. I've got clients out here doing 9%, 10%, and I don't know who these people are at 20% of the time. We're just not going to talk about them. But I want you to see this because since the preponderance of you are in here, I want you to realize you have friends who are in here. And this is another example of you will not be paid for your work if you do not bill it. Let's keep going. Missed visit volume. Don't you want to know how bad your missed visits are? Everyone says, oh, we have the worst patients of all time. My patients never show up. I assure you, most of you are right in here, 4 to 5%. Sadly, I have practices whose no-show rates are 10, 15, 20%. You know, it's largely constituency based. I've done a lot of work on this particular topic, but this is what it looks like. But some of these people know something. All right. I'm going to skip this one. I want to get to this one. Sick to well visit ratio. This number is vital. I told you I can do parlor tricks and I can tell you a lot about a practice with just a handful of numbers. This is one of my magic 3 or 4 of them. Your sick to well visit ratio. It's really simple. Add up your sick visits, 99212s, 9921 or 99205s, whatever. Add those up and compare them to 99381s, 99392s, and so forth. This number, let me show you, over time, 20 years ago, you used to do 2.7 sick visits for every well visit. 20 years ago, you lived on otitis media and diaper rash and pharyngitis and UTI. If your business right now as pediatricians requires that, you're in big, big trouble. And that is a lesson you should have unequivocally learned during COVID. Your job over the next 20 years is pandemics, mental health, well visits. All right. Especially because, and I've said this in this room before, the overwhelming majority of things that you treat as pediatricians I could do. I could fake being a pediatrician for a long, long time. And all right. Well, many people do. Well, CVS is doing it right now. Okay, Google does it for you. Yes. And so I'm not trying to be offensive. I'm just saying people are doing it to you right now. Your special sauce is those well visits and so forth. But look at how much that number has dropped, and look at what happened in 2020. When I said all of your preventive care measures were at peak. All right, I have 30 seconds. This is what your well visit coverage looks like nationally across the board. What is horrifying is that 71%, that means 30% of your active children have not had a well visit. Some of them in less than the last year, because I've got numbers for sub 3-year-olds. Here's what it looks like on an age bracket. Your 15 to 36-month-olds are pretty low. That yellow line, that's the median line. Okay. So half of you, in theory, are below that line. Look at that blue line. That's 10% of the pediatricians in the country. 40% of their kids, of their 3 to 6-year-olds, haven't had a well visit in a year. That makes me cry a little bit inside, on the outside too. But it's like that horrifies me. Really quickly, again, you're gonna have to go in these. I have child vaccination stats. This is the childhood groupings. All right. You can see them individually. All right. Or later on, because boy, I bet they wish they had one of those giant crooks, like they could pull me off the stage. You can go look it up. I have numbers for HPV in here. I have meningococcal. I have developmental screening. I have fluoride varnish, all of those preventive care measures that I'm actually going to talk about this afternoon. As I said, I was going to run out of time. My time is up. I hope this made some little bit of sense. All right, they're going to come give me the hook, and we have our next speaker. I will see you this afternoon, though. Thank you.